I'm Bronwyn. I'm the CEO of Allied Health Professions Network, otherwise known as ARPA. So ARPA is primarily an advocacy-based organisation. We are the recognised national voice for allied health professions in Australia, and our members are the peak bodies for each individual allied health profession. The allied health sector is actually pretty big. We make up over a quarter of the entire health workforce, and there's an estimated 150 to 200,000 allied health professionals in Australia. So ARPA primarily advocates on system-wide issues or on advocacy issues where we're likely to see a better result when we work together as a collective. So the member organisations of ARPA will run individual discipline-specific advocacy or strategy, and then ARPA will work into areas where there is either whole of sector engagement or, as I said, where we're likely to get a better result as that collective. So many of you will be aware that in allied health there are multiple third-party payers. So we've got the NDIS, aged care, DVA, mental health, private health insurance, and then all the state jurisdictional compensation and compensable schemes. So one of the biggest challenges for ARPA and our member organisations is selecting which advocacy area we're actually going to prioritise. It's quite a dynamic environment. It's really heavily influenced by changes in government and the initiation of new reforms, which occasionally can catch us by surprise. So ARPA at the moment has 5 core advocacy areas that we would consider to be our priorities. The first 2 are very much system-wide issues. They are workforce and digital health. So if we park them to the side, we can unpack them a little bit in a moment. And the other 3 are aged care, disability and mental health. There are large numbers of mental health professionals. There are large numbers of allied health providers working in the disability sector. And obviously in aged care, there's significant reform happening at the moment that warrants the time and attention of ARPA. To go back to workforce and digital health, they are 2 topics that are completely interconnected. In workforce, at the moment, we have no national allied health workforce strategy. What that means is that we have no accurate, nationally consistent way of collecting data that tells us about the supply of each individual allied health profession, nor of the distribution. So, for example, if we looked at individual professions, they may have done some work to better understand the distribution of their workforce across the country. But looking at allied health as a whole sector, we don't really have a very accurate picture of where allied health professions are actually working, nor importantly for how long they intend to remain in practice. So a strategy, an allied health workforce strategy, is really important because it serves 2 functions. It allows us to plan for future workforce and make sure that we have sufficient supply and distribution, but it also facilitates service planning. And we can't complete comprehensive service planning without a strategy in place. To briefly touch on digital health, the primary issue for digital health at the moment for allied health is that we have the My Health record, and in the primary healthcare setting, allied health providers are not able to upload into the critical summary or the critical event summary of the My Health record. So that means they can view the My Health record, but they cannot upload their content. That is materially important if we have the expectation that allied health providers are going to work within multidisciplinary teams. So a very practical example would be that if you're a client with diabetes and you visit your podiatrist, the GP or the endocrinologist cannot see any of that service interaction that happened with the podiatrist. And it also means that the podiatrist at the point in time may or may not be able to see what's happening at the GP and the endocrinologist level unless they are actively participating and uploading into the My Health record. So that continues to be a high priority for ARPA for the foreseeable future. The key areas of practice in allied health often get a little bit confused with settings and sectors. So allied health professionals work across a range of settings and sectors, such as residential aged care facilities and in-home care, in disability services, in schools, in private practice, community health services, and acute care settings. And then each individual discipline has its own scope of practice. So an example of a scope of practice area might include rehabilitation or chronic disease management, musculoskeletal health or mental health. And if we take mental health just that little bit more deeply, Mental health care services are provided in school settings, in private practice settings, and in residential aged care settings, and everything in between. ARPA was really pleased to be involved in this Strengthening Medicare Taskforce. So, as many of you would be aware, ARPA was originally involved in the 10-year Primary Healthcare Plan Steering Committee. And from the outset, we were really heartened to see that in the taskforce this time around, there were a number of different stakeholders and representation from different organisations that weren't visible in the 10-year primary healthcare plan. The most significant addition for ARPA really was the Australian Digital Health Agency, which I think has materially impacted and improved the work that we're going to do with the agency around digital health. The ARPA chair, Anthony Nicholas, represented ARPA on the taskforce meetings, and the final report does hold a number of key recommendations that do have application for allied health. The first, probably and most important one, was the recommendation to fast-track work to improve the supply and distribution of allied health. And that recommendation sat amongst other workforce, such as general practice and nursing and midwives. It's a really important recommendation for allied health because there are certainly significant issues of both supply and distribution in allied health. But what's really important and what sits underneath that recommendation is without a national allied health workforce strategy, we actually have no accurate picture or accurate way of describing and determining both the existing supply of allied health per discipline, nor the distribution that we currently have of the allied health workforce. So whilst we're very supportive of work to fast track supply and distribution issues, until we get a very accurate picture of the current state of play, there isn't any further work that can be done until we've got a good understanding of the status quo. So that's a particular area of focus for ARPA and many of the member organisations out of the Strengthening Medicare Taskforce report. The second one that's really important is the recommendation to increase investment into the Workforce Incentive Program, which is the WIP. So the intention of the WIP is to support multidisciplinary teams in general practice. And the report itself, or within that recommendation, it actually states that the WIP is designed to improve responsiveness to local need. It's designed to empower team members to work to their top of scope, and it's considered a means of improving accountability. Now, the issue that ARPA has with the Workforce Incentive Program, of which we've been advocating for several years to the Commonwealth regarding this, is that there is no evidence to suggest that the WIP in and of itself actually produces enhanced or better multidisciplinary team care. One of the key issues that we have had is getting access to publicly available data, which actually tells us how many different allied health professions were employed underneath the WIP. And without adjustment in its current form, there's no requirement for general practices to demonstrate local need. So no requirement to match employment of an allied health provider to local need. So from our perspective, there would need to be considerable change to the way in which the WIP is actually operationalised in order for it to actually achieve its goal of improving multidisciplinary team care. The third recommendation that also has application is the desire to increase commissioning of allied health services via PHNs to supplement general practice teams. So ARPA is very supportive of exploring new ways or models of practice or ways in which PHNs can actually engage with the allied health sector and better support commissioning of allied health services. By comparison, it's quite a different mechanism to the Workforce Incentive Program because local commissioning of allied health services by its very nature should more closely align with local need because it's at a regional or a population level by PHN. And then the fourth one that is really important for allied health relates to modernising the My Health record. So there are a suite of recommendations around digital health. The most important in there is the recommendation to modernise the My Health record and provide an uplift in primary care IT infrastructure. I would like to think that in that recommendation to uplift IT infrastructure, that allied health is actually included in that recommendation. I'm not sure that they are. It certainly doesn't specify allied health. But as we touched on earlier, one of the key issues that we have in allied health is our inability to actually upload content, critical information content into the My Health record. So we're particularly keen to foster strong relationships with the Digital Health Agency, and to continue to plan how we're going to bring allied health into the existing digital ecosystem. So this is a really interesting question. And if we look at it at a more granular level, at really the interaction between a client and the allied health provider, the availability of client data is increasingly really important. So there's an expectation from consumers now that the data that they collect on their iPhones and their watches and all the other ways in which we collect health data is used to inform care planning at the point of time, at the point of care. So we call it point of care data, and we look at the way in which we can collect all various bits of data and information about the client at that point of care. It's really important for the allied health provider, if we look at them first, that they are able to both see all the other relevant healthcare interactions that have taken place, obviously with the client's consent, and that the client doesn't have the experience of reiterating their story over and over again. Probably one of the most obvious areas where this occurs is in the mental health space, where clients may move in and out of the acute into the primary healthcare setting, but also for chronic disease management. So if we go back to the Strengthening Medicare report and the desire to improve chronic disease management and the desire to improve multidisciplinary team care, in order to actually deliver against that, then the allied health provider and the client need to be able to see their health data in real time. In its current form, if allied health are not able to upload the outcomes or the management plan of their treatment session, and the client goes back to their GP for a follow-up appointment, the GP is not able in any way to see the interaction that may have occurred earlier that day or earlier that week with, say, the podiatrist and the client. This becomes really important in areas where we may have disability services at place. We might be talking about a paediatric population. We might be talking about people for whom English is not their first language. So it's really important that we get to the point that we're able to talk about data exchange and better utilisation of the My Health record in order to stop consumers having to consistently and constantly repeat their story to each healthcare provider that they see along their continuum of care. Our priorities for the upcoming federal health budget relate to the recommendations in the Strengthening Medicare Taskforce. So there are really two key areas that we are most interested. The first is funding to support the delivery of and implementation of this National Allied Health Workforce Strategy that includes all the various settings in which allied health work. It's a really important point because I think the temptation is that we tick the box by developing an allied health strategy, but we only look at workforce in health. But remember, we have workforce in health, disability and aged care and education settings. And if we're genuinely going to look at issues of supply and distribution, we have to look at the distribution of allied health professionals across all of those different settings. The second one is further work and investment with the Digital Health Agency to bring allied health into the My Health record. So as we touched on earlier, digital health, well, access to the My Health record is an enabler to multidisciplinary team care. One of the core recommendations or functions of the Strengthening Medicare report is to enhance and build and foster multidisciplinary team care. But the way in which you go about doing that is to create digital interoperability and to bring allied health into the existing digital ecosystem. So those two pieces of work, workforce and digital interoperability, are really interconnected for us, and they are both fundamental to the Commonwealth being able to deliver against the recommendations in that task force report.